University Medical Center Groningen. And I have recently joined DASH, also because of a focus on big data, cohort studies, and AI. And within DASH, there are different focal points, and you probably who have found this webinar have already been introduced to DASH, but the focal points from DASH range from community building in data science and AI, help with information about funding opportunities, an incubator for collaborations within the UMCG and outside of the UMCG, a machine learning lab, education and communication. And it's my pleasure to be moderating this webinar. Can you go to the next slide, please? Well, before we start, I kindly ask all the attendees to put your microphone on mute. This video will be recorded and will be available later for viewing. And also on the request of the speaker, you're very welcome to put your questions in the chat, and then I will ask them to the speaker. Or you can raise your hand in this collaborate environment, and I can give you the chance to ask the question yourself. And you can do this also during the lecture. Next, please. So it's now my pleasure to introduce the speaker of this afternoon. It's Laure Wynants. She is an assistant professor of epidemiology at the universities of Maastricht and of Leuven, both very nice student cities. If you haven't been there, it's a really nice place both to visit. And her research focuses on the development, validation, and impact of clinical predictive models for diagnosis and prognosis, and she's interested in methods to deal with heterogeneity between populations and in the clinical utility of prediction models. And her applied work is very diverse and deals with models for gynecological cancers, bloodstream infections, and COVID-19. And I think the COVID-19 is a very, very current problem and a very current topic of research. So we're very happy that Laure will introduce us to her research in this field and her perspective. Laure, the floor is yours.
Hi, I hope you can hear me.
Yes.
All right, thanks for this kind introduction. And thanks for the opportunity to talk here, to speak here. So what I will be talking about in the next half an hour approximately looks like this. So first I want to delineate what I mean with AI models or models for diagnosis and prognosis of COVID-19. Why look at them? So maybe you have heard that we've done a living review of them. So why did we do it? The methods, how and when did we do it? And the results. And then the second part is more focusing on some of the issues that we encountered. So the biases that we found in those models. So to have a good discussion, it's important that we all understand what we mean when we speak of bias, because depending on your field, you may interpret that differently. Discuss our findings a little bit in a broader context, and the lessons that I learned from doing this work. I would also like to share those with you. So first, what are we talking about here? Well, scientists can lose themselves in discussions of what is now exactly AI, what is machine learning, what are traditional statistical models, and what is the distinction between all those. Whereas for the policymaker, they seem to take very broad definitions of AI. So this is from the European Commission. You see that they are actually referring to all sorts of machines that can do a variety of tasks that humans can do, such as recognizing pictures or taking decisions. Also in the Netherlands, in policy in the Netherlands, they take a comparable broad definition. So an AI-PA is actually an AI predictive algorithm or a complex algorithm for diagnosis, prognosis, secondary prevention, or treatment. So without making distinctions between the actual methods that are used to develop such models. And I took a similar approach. When I speak about diagnostic and prognostic models for COVID-19, I actually mean any data-driven model or algorithm that combines several inputs. For example, the demographics of a patient combined with their symptoms, combined with biomarkers, or combined with an image, or even an image alone, so that you look at various image characteristics, that then predicts an outcome, for example, a diagnosis or a prognostic outcome for an individual patient. And that can then subsequently be used for clinical decision making. As I know that I've been told that people attending these seminars have very different backgrounds, and there is often some confusion in terminology. So I will be using these terms sometimes interchangeably. So if that confuses you, take a screenshot, and then maybe this can come in handy during the rest of the talk. But I think that apart from terminology, these fields actually have a lot in common. So they are actually trying to do the same thing. So these diagnostic and prognostic models, why review them for COVID-19? Well, the reason is that from the very beginning of the pandemic, really the very beginning, everyone was looking in their direction to learn from data. So this was a novel disease. Clinicians and policymakers didn't really know how to manage these patients or people who may have COVID-19. So companies, governments, universities, individual researchers, clinicians, they all had an interest in this right away, and with some real effects in the real world. So for example, in the UK, models have been used to put vulnerable people on the shielding list. So each of these patients, based on their individual risk of COVID-19, got a letter from the government telling them to shield. In the United States, several algorithms have received FDA approval for use in the clinics to manage COVID-19. So it was in use, and all this attention, I think it's justified, because we know that a good model can improve care and reduce healthcare costs. An example from my own university is a model to predict pregnancy complications. So in an intervention study, a trial, it was shown that using this model and coupling the treatment of a pregnant woman or the monitoring of a pregnant woman with her individual risk can actually halve the risk of pregnancy-related complications, while simultaneously making care cheaper by giving the right care to the right patient, the patients who need it most or the patients who would benefit most. And especially in this in the situation in the pandemic, this would have been very useful, because it's not so long ago that we didn't have enough testing capacity, and that ICU beds were full. So this would have been very useful. Now, there's another side to that coin, and that is that's important to realize, because a poor model can actually make matters worse. So an inaccurate prediction can lead to harmful clinical decisions. That means not just worse than a clinician working without such a model, but even worse than treating all patients as high risk or all patients as low risk. So you can do worse than that. And there is a precedent. During the swine flu pandemic, ICU scores that generally work very well were demonstrated to have to not work well in that population. So we should we should critically look at these models before we introduce them into practice. So that's why we decided to start a living review. So how did we do it? When did we do it? Well, the first version of this work, it was not planned to be a living review. It was, in early March 2020, we got the idea that we had to look what was out there, what was available, was it any good, and could we adapt it for the Western European population, because a lot of the data at that time came from China. So that was the plan. We had our first publication in April in the BMJ, and then because there were so many models and the problem of COVID wasn't solved, models kept appearing. So we were asked to make it a living review, and that's what we did. So we did 3 updates since. We have 3 updates published since, and we're still working on the 4th one. So how did we do it? Well, what did we include? We did a systematic literature search of peer-reviewed and published work on the topic, but also preprints. Until the 2nd update, we also included the preprints. We did that because, of course, in the very beginning, traditional publishing wasn't keeping up. So it was too slow for the situation. So we decided to include the preprints. And if we have a preprint included and later on it's published, then we re-review that same work and re-include it. So the type of models that we looked in can be broadly split up into 3 categories. So first you have your models for susceptibility. That means in the general population, people who are healthy, what's their risk of getting COVID or getting COVID with severe complications or having COVID at this moment? So people who are now healthy. And the second type of model are the diagnostic models. So people in which you have reason to suspect COVID, for example, people who had a high-risk contact or people who have symptoms. What's the risk that they have COVID-19, or do they have COVID-19? Do they have something else, classification problem? And then the last type are the prognostic models. So, oops, my slides are moving. I don't know what's happening. Yeah, the last type are the prognostic models. So for the people who have COVID, what's the course of the disease? Are they likely to die? Are they likely to need ICU? Things like that. So for the data extraction, each study was looked at in detail by 2 independent researchers. If they couldn't agree on the data that needed to be extracted, they discussed until they reached consensus, or a 3rd reviewer intervened and solved the conflict. If more than one model was described in an article, each model was assessed separately. So we looked at more models than there are papers. And for data extraction and critical appraisal, we used the CHARMS checklist and the PROBAS tool. The PROBAS risk of bias tool, I will come back to that later in a bit more detail. Then as for the results, in total, we screened over 37,000 records. From those, we included 170 studies in our review, and together they proposed 236 models. 11 models to identify subjects at risk in the general population, 118 were diagnostic models, and 107 were prognostic models. And if you look at the origin of the data, most of them use single country data, and very often stands out that that data was from China. But in the meantime, really, models have been published with data from all over the world. And then if you look at the care settings and the populations where these data came from, this was mostly hospitalized patients with confirmed or suspected COVID-19. That makes sense because that's where most of the data is. But what's really important to notice here is that half of the models that have been proposed are also available in a format for use in clinical practice. That often means that you can simply go to a website and anybody who wants to can fill in a risk calculator or upload a picture and get an outcome for an individual patient. In terms of the methods used, about 1/3 used logistic regression, another third used neural networks or deep learning, and then the rest of them, there was really not any dominant modeling technique. There was Cox regression, support vector machines, random forest, just to name a few. And then in terms of the predictors that are included, the broad categories, the top 5 categories, were for the diagnostic models, vital signs such as fever, flu-like signs and symptoms, age, electrolytes, image features, and for the prognostic models, that's age, comorbidities, vital signs, image features, and sex. Now, you really want to know, of course, how well these models did. And at first sight, this looks like extremely good news. In case you don't know, a C statistic, and that's what I present here, the C statistics ranges from 0.5 to 1. And you see that for all types of models that we looked at, you have models discriminating nearly perfectly. So that should be a cause for a mass celebration, because it means you don't need a PCR test. And you can perfectly predict who will die from COVID and who will not die from COVID, for example. So that looks like very positive. But if you look a little deeper into these results, you will see that the majority of these models have a high risk of bias. 226 of the models that we looked at had a high risk of bias, and only 4 of them were low risk of bias. That means that the majority of models, we cannot trust the performance that the authors of the study report. It's likely to be lower in reality. That brings me to the next slide. So what you see is that these problems, these biases, occurred for all types of models that we looked at. The reason for the bias was a little bit different depending on the category. Other reasons were dominant, but there were problems everywhere. So what do I mean when I say bias? What is bias anyway? So depending on who you ask, you might get a different answer. So if you're a policymaker or you're an ethicist, you may think about bias and fairness. For example, algorithms replicating or even exacerbating racial or gender biases. That's not what we looked at. A machine learner might think of the bias term or the intercept term in a regression model. That's also not what I mean. Sometimes they also speak about prediction bias, which is the difference between the average of the predictions and the average of the labels. That's what statisticians would call calibration in the large, but that's also not what we mean. So a statistician, and now we're getting a bit closer, a statistician distinguishes between bias and variance. And bias is just about how wrong you are on average. So if you compare it to throwing a dart at a bullseye, you can always draw at exactly the same spot, but far from the bullseye. So then you have a low variance but high bias. Or you can throw always, well, on average, you're at the bullseye, but you're dispersed all over the dartboard. Then you have a lot of bias, a lot of variance, but on average, you're correct. So you have a low variance, low bias, sorry. The ideal situation is that you always throw the dart directly into the bullseye, that's a low bias, low variance situation. So that's what we want when we make predictions. So this is what statisticians refer to, which is still different than what epidemiologists mean when they say bias. So it's actually a term that's super complex, and you can project a lot of meaning to it. An epidemiologist will, when he speaks about bias or she speaks about bias, they mean actually an error in the design of a study or in the way the data was collected or interpreted or the analysis was conducted that leads to results or conclusions that are systematically different from the truth. And this is actually more in line with what we mean with what this review means when it talks about bias. So epidemiologists love bias. They actually have a whole website, a catalog of all sorts of bias that may arise in a study. But to target it a little bit more, in a prediction setting, I think what we're after is that we want to know whether there are shortcomings in the design of the study or in the conduct of the study or in the analysis that could lead to systematically distorted estimates of a model's predictive performance. We want to know how good the model is, and if we made errors that may over or underestimate that performance, we actually have introduced a risk of bias. So the PROBUS tool was invented to look at different sources of bias in a study. It actually asks a set of signaling questions in 4 different domains. So it thereby is an aid in detecting common reasons for bias in terms of the participants that were contributing data to the study, the predictors that were used as inputs for the model, the thing that you're trying to predict, so the outcome of the model, and the analysis that you did to build your model and to test it, to validate it. So what was the reason, or what were the reasons for the COVID models? Well, there were a lot of problems with the participants, in meaning that very often the data that was used was not representative of the clinical target population that you are actually making this model for. So it's not reflective of the patients that you would see in clinical practice. There are also problems with sometimes less problems, but sometimes there are also problems with the predictor and the outcome data. So in terms of the predictors, sometimes you use data that actually isn't available in that format at the moment that you want to use the model. So you want to make a model that predicts how a patient will do at the moment he is admitted to the hospital, but you're using data that's not available at that time point. So that makes the model not fit for clinical practice. Sometimes the predictors are biased in a sense that they already include part of the outcome. So we saw models that use fever as part of their outcome definition and as a predictor. Of course, that's going to inflate your performance. The outcome labels, sometimes this was not much of a problem. I'm going to ignore the questions for now and come back to them later. I see them pop up, but the outcome, so sometimes the outcome was also problematic. We saw crazy things like people simulating outcomes, people using people predicting non-COVID disease. So for example, other respiratory illnesses, or admission to hospital with other respiratory illnesses from before the pandemic, and then market those models as COVID models. So that's an example of a biased outcome. But the top 3 errors and the most problematic domain was actually the analysis domain. And that's really striking to me, because when you build a model, the analysis, you do that yourself. So these are all preventable errors. And the top 3 were sample size, model performance measures, and optimism. So I want to show you a few examples of, well, some of the things that we encountered in our review. So if you look at sample size, this is a little quote from a published study. So they had data on 296 COVID-19 patients in their training cohort, of which 19 people died during hospitalization. And then they might make a model predicting death. Now, you have to ask yourself, how much can you learn from 19 cases? That's really extremely low to build a data-driven model. And this is not an exception. Of course, I chose a particularly bad example, but the median sample size was just a few hundred patients. And the median number of events, so that the lower outcome category of the thing you're trying to predict, for example, death, if you predict survival, or COVID-19, if you have a diagnostic model, that was just 17. So based on the events per variable criteria, which is rough criteria we use, 70% of the models that we reviewed actually had insufficient data for the modeling strategy that they chose. Another problem was the evaluation of model performance. So we're all used to ROC curves, and you see here an example. The green arrow indicates that for this particular model, it does a very good job at discriminating between people who need mechanical ventilation and people who don't. It's really performing very well. But if you look at calibration, you see at the red arrow that indicates that people with a predicted risk of needing mechanical ventilation of 2%, in reality that corresponds to a 10% risk of need of mechanical ventilation. So not 2 in 100 patients, but actually 10 in 100 patients will need mechanical ventilation. That's miscalibration, and you would want to know that if you're going to use these predicted risk in clinical practice. The problem is that most studies don't look at calibration. So they only see this picture and the model appears perfect. And it's 68% of models that did not have an appropriate evaluation of discrimination and calibration. Also, this was a published example. And the third issue is optimism. So you see here that the majority of models were not externally validated. They were only internally validated or even not validated at all. So you don't really get a good idea of the predictive performance in an independent data set or in real patients. And if they did internal validation, which in essence it's fine, it's correcting for optimism in your performance if you do it the correct way. But we saw some strange things. For example, this study, they have this very complex algorithm of determining which predictors they include in their model. It's based on a genetic algorithm. And then you see that they only set the test set, the validation set, apart after they chose which predictors go into the model. So they're leaking information. The predictors that they chose are already optimized for that test set. So that's another reason why you may overestimate your predictive performance. So actually, about half of the models that we saw did not appropriately account for optimism or didn't try to account for it at all. And there are some other nice examples that of problems that we kept seeing over and over again. For example, dichotomizing time to event outcomes and throwing away all censored cases. So this is a case where they had 748 patients, and they wanted to predict death with COVID-19, but over half of the data were still in follow-up. They were still hospitalized, so they threw away that data. That's a huge waste of information when you have survival techniques available that can perfectly deal with censored data. Another one that I kept seeing is predicting death without making any restrictions on when the predictors are measured. So this is an example of a published study where they used the highest or lowest value recorded of its kind. So that means they took the highest body temperature throughout the whole patient's stay, or the lowest oxygen saturation level throughout the whole patient's stay. And that can lead to some interesting patterns in the data. So this is a plot from the same published study. And you see here this odd peak indicating that there are actually, among the patients who died, there's actually quite a lot who had an oxygen saturation, a minimum oxygen saturation throughout the patient's stay of 0%. I found that remarkable. And I thought, what's going on here? So I asked around a few clinicians and they said, well, actually, that doesn't even happen when you're dead. So what's likely to be wrong here is that at a certain point, the oxygen saturation fell below the detection limit of the monitor the patients were hooked up to. And it reported an oxygen saturation of 0, but it was actually too low to be detected. And that's something that apparently only happened in the deceased patients. So you have to ask yourself, what are you doing here? This was supposed to be a prognostic model. So are you still predicting death at a time point that's useful for a clinician? Can the clinician still act upon an alert from this system, from this prediction model, or are you actually diagnosing death? Are you actually giving a diagnosis of or a high risk of death when it's already too late to do something to save this patient? Another one that is interesting to note, especially if you work on images, is that there were a lot of Frankenstein data sets which were then disguised as case control studies. So what do I mean with that? Let's have a look at this quote from the study. So in this study, there were 1,042 chest images, and then 521 were from people with COVID-19, 397 were from healthy people, 76 were from people with bacterial pneumonia, and 48 were from people with SARS. And how did they get these data? Well, they searched exhaustively for all available data on the internet. So there's a few issues with strategies like this, combining repositories that are available online or are available somewhere. And one of them is that rarely or never is representative of the type of patients that come in for a CT scan with suspicion of COVID-19. The second problem is that there may be a lot of confounding going on here. So what happens sometimes is that the training set consists of people with COVID-19 who are, for example, all adults, while the controls are all images from children. That's a strange thing that happens. Or the position of the patient may vary, or the machine that the patient was scanned in with may be different. So you can have all different sorts of differences between the cases and the controls that are not related to COVID-19 at all. So you don't know what your model is picking up anymore. A third problem with this approach is that these data sets, combining other existing data sets, sometimes it happens that a single repositories include the same image. So the same image is included in different repositories, and the researcher combining these repositories doesn't know this, doesn't realize this. And then they do a train test split, and actually the same images are included twice, once in the training set and once in the test set, again inflating your predictive performance. So that is what is meant with this term Frankenstein dataset, which was coined in this context, and I think it's an interesting comparison, or an interesting word for this problem. Very often it was not clear when the model was intended to be used, in what type of patients it was intended to be used. The reporting was often very poor, and this made me wonder more than once, is this really something that's intended to help with this pandemic? Is this really something that these researchers want to be introduced into clinical practice, or is this a modeling exercise? Is this something that they did for the fun of modeling, for the purpose of just to research, but not thinking about clinical practice? So you may think that I'm too critical, that I'm exaggerating. Well, well, that's a very valid question, of course. Risk of bias doesn't necessarily mean that the models are also not good at predicting. It's just indicating that there's a risk that the performance may be overestimated. But we do see when these models are validated externally, so when they're tested on independent data sets, for example, data from another hospital or validated by another researcher, that the performance deteriorates. So you see here in these plots, you see when the curves, the colored curves, are falling below the dashed horizontal line, you see that means that the models that are meant to detect deterioration of a patient are performing worse than oxygen saturation on room air alone. And in the second panel, the models are to predict mortality are performing worse than age alone. Now that's really an accomplishment, because most of these models also include age as one of the predictors. So yeah, it is a clear indication that things went wrong in the modeling phase and that there was overfitting. Then our review was picked up and by policymakers, and the World Health Organization followed or agreed with our concerns, and they recommended not using any of the models that have been proposed for use in the clinic. So what's in store for the future? Well, we're still working on the next update. We have another 251 studies that have been reviewed, and I'm analyzing the data now. So that's already doubling everything that we've done so far, so more than doubling. So there are really a lot of models out there. And this is with a restricted focus. So because it was so much, we decided to focus only on the prognostic models, and excluding also the models that use images alone as inputs. But there's also good news, because there's also, with this latest update, I will include the 4 low risk of bias models that we found. Those are the 𝐃𝐚𝐭𝐚 models. So those are, in fact, the models that I referred to earlier that were used by the UK government to recommend people to shield. And these models detect in currently healthy people and the general population who's at highest risk of catching COVID-19 and then subsequently being hospitalized with it or dying with COVID-19. And they were developed with data from 910 general practitioners, over 6 million patients. And they were also externally validated in a huge external validation study. They had data on 80% of English adults, so that's almost the complete population, which is amazing. It's an amazing effort, and they had excellent performance. So you can, it's possible. Some of the limitations of our work is that I'm aware that there are other models out there that I did not pick up with my review. We tried, but it's not easy to get a hold of them and to review them. So there are in-house developed models by hospitals that are never published, or proprietary algorithms by companies that are not accompanied with a scientific report, and we could therefore not review them. However, I've seen a few of those. We managed to get our hands on documentation on a number of them, and there are indications that their quality is not better. So I don't think that we picked up the worst of it. Yeah. So what lessons should we draw for the future? So the lessons that I distill from this is that, well, data science and machine learning and AI and predictive analytics is hugely popular, and that leads to a tsunami of models in which no one has an overview anymore of what's available, not even us, and we were doing the systematic review. So a tsunami of models, and that's a problem because a lot of these models are of dubious quality. So in essence, when you want to identify a model that's good for your patients that you can use in clinical practice, you're looking for a needle in a haystack. And I think that too much competition is actually threatening our patient safety. So I know that a number of the models that we've reviewed have actually been marketed or have been recommended for use in patients by guidelines, and that some of these models have been used in clinical practice. And I think a lot of that was due to the rush of getting these models into clinical practice and being in competition with one another, and that maybe a few steps may have been skipped here. Even in the context of a pandemic, that could be problematic. So how can you do better? How can we do better in general? And how can we do better if we ever encounter a pandemic before, where models could actually help us when clinicians are still figuring out what to do and we could learn from data? Well, I think the first thing we need to do, if you're a machine learner, or if you are an engineer or a data scientist or a statistician, use the methods that are out there that prevent overfitting and optimism, and use them rigorously and be critical of yourself. The second thing that we need are large, high quality data sets, but it's not just more data is better. You also need representative data sets. So the data that you have has to be representative of the population, the clinical target population that you want your models to be used in. Maybe that's not always necessary for building the model, but I think certainly for testing the model, you would want those representative databases to make sure that your model works as you think it does in real clinical practice. Then I also want to advocate for sharing models. I think it's important that models are available as an equation or as a software object, so that other people, independent people, can test their models on independent data sets, so that we really know how models do these, how well do these technologies perform when they are validated independently. And the last thing I think we need are multidisciplinary teams. So we saw both type of problems. So one problem is clearly technically highly skilled people who don't have a feeling for what's needed in clinical practice. So models that are not fit for purpose. And the other side of the coin is, or the other problem that we saw, were models that were built by clinicians, but were built in a very amateuristic way. So by working together, we could really do a lot better, I think. So this is what I wanted to tell you today. These are my acknowledgments. And if you want to know a little bit more, on our website, we have a summary, a layman summary written by and with survivors of severe COVID-19, so a layman's summary, but also the results of all the, or more detailed results on each model that we reviewed. And if you have any questions that are not addressed in the Q&A, you can always write me.
Thank you very much, Laure. It was extremely elucidating on this very hot topic of models in diagnosis and prognosis of COVID-19. I think we've all seen many surfacing in the last, year and a half. Before I ask my questions, I checked the chat, and please, all the audience, feel free either to raise your hand if you have a question or to put your questions in the chat, because we still have about 10 minutes to ask Laure our questions. And I already see one question in the chat from 𝐃𝐚 𝐒𝐤𝐿 around, and that is from earlier in the presentation. You mentioned almost 50% of the models were fit for clinical use. What makes a model usable in a clinical setting according to your definition?
Yeah, so that 50%, that's they are available for clinical use. So the authors made an equation or a nomogram or a score chart or a website with a risk calculator, or they mention that it's used in the clinic. So that doesn't mean that it's necessarily fit for clinical use, because I think fit for clinical use means something else, but at least anyone, any doctor who would want to use the model could do it. They provided tools to do that. That's what I meant.
And then the follow-up question would be, what would make a model useful in clinical practice from your expertise?
So what would make a model useful for clinical practice? Well, there's a lot of answers that you can give. So first, I think there needs to be a clinical need. That's the very first beginning, because you can make a very nice model, but if no doctor feels like they need the support of a model for that, then you're creating demand rather than offering a solution to a real problem. That's one part of it. And the second part is that I think it needs to be validated extensively. Then ideally you could do but maybe not in the context of a pandemic, that would not have been possible, but outside that context, you could do a trial. So you could, or an interventional study where you really compare the model with clinical practice, usual clinical practice, because how a model is used and how it is intended to be used, that is not the same thing. I have a very bad echo. Could you please turn off your mic? Could you please mute yourself? I hear myself talking. Yeah, okay, that's better. So yeah, trial or a health economic assessment, a cost effectiveness analysis, involving the stakeholders and designing the tool that's built around the model, that could help too. So that's, yeah, it's a really multi-layered response. I realize that.
Okay, thank you. There's another question from the audience. Bart Scheerder asks, thank you for the nice presentation. You recommend using high quality representative data. What are your thoughts about how to find and access such unique resources?
Yeah, that is actually the big problem, isn't it? Well, I think we need collaborations with clinicians to collect that data. And high quality data is not just, well, high quality doesn't mean the best measurements possible. It means measurements representative of what you will use as inputs for that model. So you don't need it to be higher quality than what you would typically have in clinical practice, but you need systematically recorded data on, for example, all consecutive patients for a long time to get that. Also the outcome labeling. This is a problem that is often underestimated, because somebody needs to obtain the gold standard or label images or signals for a lot of patients, and that's very labor intensive. So I think it's yeah, I see a push for making a lot of data available, combining a lot of data in data lakes or health data spaces are the buzzwords. I think that may be a bit over optimistic and a bit underestimating, or maybe I'm maybe I'm seeing all of the problems and we can find solutions for that. But I think we have to be aware that, well, metadata is important, labels are important, the context, it's important to understand the context in which data was collected, so that you can be aware of certain biases. Maybe the data was collected really in a very specialized clinic where you see very complicated cases. That doesn't necessarily mean that that model built on those cases can also be used at a lower level of care in a regional hospital or in a primary care setting. So you really do need a lot of context. It's not just the data, you really need to understand what is in the data. And that's it. Yeah. Is that a good reply to the question, Bart?
Thank you. That was a very extensive and a clear answer. Another question is from Xavier, and he's asking regarding the use of models in actual clinical practices. A model predicting death might be very difficult to use due to ethical issues. However, predicting how long a COVID patient would be in ICU might be more practical. Do you know if there are similar studies done regarding models predicting the length of stay for COVID patients in ICU?
Yeah, I think that's a really putting the I don't know, vinger op de wonde.
Nail on the head.
Yeah. What you often see in these cases is, yes, I would advocate for models that actually predict length of stay in the ICU, and then you can say, for example, death or discharge within 10 days, within 5 days, within whatever is reasonable or important. And yes, there are some out there, but very often, instead of using length of stay, which is often translate to using a survival modeling approach, which is always a little bit more complex than using a dichotomous outcome approach or a binary outcome approach or classification approach. We saw a lot less of them, but they are out there. Yeah. But doing it that way would circumvent a lot of the issues with the dichotomizations that we saw and throwing out all of the data of all of the patients who are still hospitalized. Yeah.
Thanks. What was also very elucidating is the teaching point you mentioned. I think that in the last 2 years in the machine learning world, modeling world, we were in a fast cooker where everybody wanted to make his own model to help in the COVID pandemic. And I think that we can learn a lot from things that maybe went wrong or could be better, and also teaching points going forward. And I think one of the points you mentioned, for example, that you combine, and from my perspective as a radiologist, that researchers use, for example, COVID patients and then young children as comparison of images. Of course, then there's nothing really to teach your model. It's self-evident that they're completely different populations. So I think that this whole period of COVID-19 pandemic can also teach us a lot going forward. And so thank you also for addressing that. I think the questions have been answered. Thank you so much again, Laure, for this great presentation, and good luck with updating the BMJ systematic review. Of course, we hope that we will be out of the woods of COVID-19 for the upcoming winter. but the evidence will be still very relevant, of course, to summarize and going forward. Thank you so much, and also thank you so much to the audience who was here. I would like to advise you to keep up to speed with the DASH updates on the website, social media, and look out for the next webinar, which I'm sure will be before the end of the year. Thank you so much, everyone, and I hope you will have a really nice evening. Till next time.